Richard J. O'Donnell, Stephen G. Du Bois, and Daphne A. Haas-Cohen. Introduction. Sarcomas, defined as connective tissue malignancies, can be said to constitute one of the 5 major oncologic subgroups, together with disorders of the solid organs carcinomas, the hematologic system, the skin, and the neurologic organs. Of all cancer types, however, sarcomas are the rarest, and in fact, exceedingly so. Furthermore, sarcomas of bone occur at just 1/4 the frequency of sarcomas of soft tissue. However, whereas soft tissue sarcomas have a multitude of histologic subtypes subject to a variety of grading classification schemes, bone sarcomas predominantly fall into 3 main distinct categories: chondrosarcoma, Ewing sarcoma, and osteosarcoma. Whereas soft tissue sarcomas are rare in young individuals and occur with increasing frequency as the middle to late decades progress, bone sarcomas, for the most part, are more common in children and young adults, with some exceptions in later years. Although the gold standard of treatment for soft tissue sarcomas remains surgery and radiation therapy, with chemotherapy reserved for tumors that are deep, high-grade, and large, the management of bone sarcomas varies considerably, according to histology, grade, and stage. Finally, all high-grade sarcomas, whether of bone or soft tissue, share an overall survival rate of approximately 55% to 70%. In light of their extreme rarity, the varied and complex nature of the care programs often involving national or international protocols, the high-stakes nature of limb salvage surgery, and the potential lethality of these tumors, the National Comprehensive Cancer Network (NCCN) has promulgated that primary bone tumors and selected metastatic tumors should be evaluated and treated by a multidisciplinary team of physicians with demonstrated expertise in the management of these tumors. The paramount and central nature of this statement cannot be gainsaid because judgment regarding management of these uncommon tumors must necessarily be left to the experts. Nonetheless, even the most general reader would err in not seeking a broader fund of knowledge and a higher level of understanding of bone sarcomas, as the hopeful and instructive paradigms offered herein can be of benefit to all oncologic patients across practice strata. Therefore, this chapter seeks to be a primer on the diagnosis, staging, treatment, and surveillance of sarcomas of bone, with information ranging from basic principles to detailed descriptions of complex algorithms. After reviewing incidence, etiology, anatomy, pathology, screening, diagnosis, and staging of bone sarcomas, management is discussed by treatment modality, with attention to stage. Ewing sarcoma, the prototypical high-grade sarcoma presumed to be potentially metastatic at presentation, is explored first. Next, high-grade conventional osteosarcoma is discussed with regard to universally accepted chemotherapeutic concepts and occasionally useful radiotherapy options. Surgery for low-grade chondrosarcoma and osteosarcoma lesions is then discussed. Limb salvage and amputation approaches for high-grade chondrosarcoma, osteosarcoma, and Ewing sarcoma are described together because the surgical approach for these 3 categories is similar. Finally, continuing care in terms of bone sarcoma surveillance and palliation is considered. Incidence and etiology. According to the American Cancer Society, there are estimated to be just 16,490 new cases of sarcoma diagnosed in the United States in 2018. 2 of these cases, 13,040, involved the soft tissues, and just 3,450 involve the bones and joints. This represents an incidence of 1 in 100,000 persons living in the United States per year. The true incidence of some bone malignancies, such as chondrosarcoma, is not well established because low-grade lesions are relatively common and no accurate registries exist. For high-grade osteosarcoma and Ewing sarcoma, the incidence is thought to be on the order of 1 per million. Another way of illustrating the rarity of these tumors is to consider that bone sarcomas, which are the 3rd leading cause of cancer death in young individuals, were estimated to have resulted in as few as 197 deaths in those younger than 20 years old in 2015. In part, this remarkable statistic is attributable to the gratifying advances in multidisciplinary management of bone tumors, with 5-year relative survival rates of children up to 14 years of age increasing from 50% in 1978 to 78% in 2008. The etiology of bone sarcomas is not known with certainty. 6 germline mutation in the T53 gene places patients with Li-Fraumeni syndrome at risk for the development of osteosarcoma. 11 germline mutation in the R-bone gene is associated with an increased risk for osteosarcoma in patients with bilateral retinoblastoma. 15 rearrangements at the EWS RON locus, most commonly fused to phenylalanine, have been implicated in the pathogenesis of Ewing sarcoma. 19 The molecular pathogenesis of chondrosarcomas is less well understood, with a variety of genes and signaling pathways having been implicated to date, including T53, hedgehog, insulin-like growth factor, cyclin-dependent kinase 4, hypoxia-inducible factor, matrix metalloproteinases, SRC, and ACT. 20 other primary bone malignancies associated with mutations, specific translocations, and genomic amplifications or gains include mesenchymal chondrosarcoma, epithelioid hemangioendothelioma, chordoma, low-grade periosteal and intramedullary osteosarcoma, and periosteal chondrosarcoma. Environmental factors are also known to be involved in the genesis of bone sarcomas. For example, ionizing radiation, either therapeutic or inadvertent, is thought to be responsible for approximately 3% of bone sarcoma cases. 42,122 independent of radiation exposure. Treatment with alkylating agents is known to increase osteosarcoma risk. 423. Some benign bone conditions predispose patients to bone sarcoma development. It is estimated that 0.3% of patients with Paget disease of bone will develop osteosarcoma, most often at an advanced age and with a 5-year survival rate of less or equal to 4%. 26 fibrous dysplasia, including its polystotic variants, McCune-Albright syndrome and Mazza-Brod syndrome, can rarely be associated with sarcomatous degeneration, including in less commonly encountered locations such as the ribs, spine, and craniofacial region. 31 individuals with benign cartilage lesions are also subject to chondrosarcoma development. Osteochondromas, whether solitary or in the multiple, autosomal dominant form, are associated with chondrosarcomas that are predominantly low to intermediate grade. 32. On a population level, the incidence of malignant change was estimated to be approximately 0.9%. 33. Similarly, chondrosarcomas have been described in patients with pre-existing solitary enchondromas or polystotic enchondroma variants Ollier and Maffucci syndromes. 34. Other benign tumors that can be promalignant include giant cell tumor, osteoblastoma, and synovial chondromatosis. 35. Even non-oncologic conditions, such as chronic osteomyelitis 3637 and bone infarcts 38 can evolve into sarcomas. Fig. 89.1. Anatomy and pathology. Bone sarcomas can occur through the musculoskeletal system. Osteosarcomas are more common in the appendicular skeleton, with the most prevalent sites being in the distal femur 32%, proximal tibia 15%, proximal humerus 8%, and proximal femur 5%. 39. This distribution corresponds to the relative activity of the physeal plates in the growing skeleton. By contrast, Ewing sarcoma favors the axial skeleton, with the pelvis or sacrum 22%, proximal femur 10%, shoulder girdle 12%, and ribs 8% being the most common locations, followed by the long bones and sacrum. 39. Chondrosarcoma similarly occurs most frequently in central regions, pelvis or sacrum 26%, shoulder girdle 14%, proximal femur 12%, and ribs 11%. 39. When found in the long bones, the epicenter of conventional osteosarcoma lesions tends to be in the metaphyses with diaphyseal extension, whereas Ewing sarcoma often arises in the diaphysis with metaphyseal extension. Juxtacortical osteosarcoma and chondrosarcoma variants occur on the bone surface. Some primary bone malignancies manifest in characteristic anatomic locations. Clear cell chondrosarcoma, for instance, most often arises in the femoral head. 40. Peristeal osteosarcoma favors the posterior distal femur. 41. Periosteal osteosarcoma is found in the anterior tibial shaft. 42. Admeninoma is most frequently encountered in the tibia and /or fibula. 43. Chordoma has a predilection for the sacrum and the clivus. 144. Finally, several histologic equivalents of bone sarcomas can be found in soft tissues and joints. Extraskeletal osteosarcoma is a rare neoplasm that has a median survival of 46 months for patients with localized disease. 45. By contrast, extraosseous Ewing sarcoma has a prognosis similar to its primary bone counterpart. 46. Extraskeletal myxoid chondrosarcoma, also an aggressive soft tissue lesion with high rates of local or distant recurrence and delayed disease-associated death, is a misnomer insofar as the tumor is really of uncertain differentiation with no convincing evidence of cartilaginous differentiation. 4748. As a rule, it is exceedingly rare for a sarcoma of bone or soft tissue to occur in an intra-articular location, but chondrosarcomas of the synovium, arising de novo or secondary to synovial chondromatosis, have been described. 49. Gross anatomic pathology varies widely according to histologic subtype, grade, and anatomic location. Although the soft tissue component of many high-grade sarcomas of bone has a characteristic whitish, firm, fish flesh appearance, gross findings can run the gamut from heavily ossified areas to myxoid, frail bled, or frankly necrotic regions, even within the same specimen. Because most high-grade bone sarcomas are 5 cm and associated with a soft tissue mass that is extracompartmental to bone, the tumor classification according to the Annecking system 5051 is most often T-Quad. Figure 89.18. Anterior posterior plane radiograph of a 64-year-old man with polyostotic femoral and tibial bone infarct secondary to alcoholism who developed a destructive distal femoral bone and soft tissue mass. E. Axial T4 weighted magnetic resonance sequence demonstrating a 13 cm distal femoral bone and soft tissue mass with cortical destruction that proved to be a high-grade, undifferentiated spindle cell sarcoma. Note the benign bone infarct and contralateral femoral diaphysis. Microscopic pathology also varies considerably among the bone sarcomas. The prototypical bone sarcoma, a conventional high-grade osteosarcoma, consists, in most basic terms, of a spindle cell neoplasm that produces osteoid. Fig. 89. 2a. High-grade chondrosarcoma will have a spindle cell component admixed with malignant cartilaginous matrix. Fig. 89. 2b. By contrast, Ewing sarcoma is a small round blue cell neoplasm for which the definitive diagnosis is suggested by strong membranous immunohistochemical staining with CD99 and confirmed by cytogenetic or molecular tests that demonstrate an EWS ROM translocation. Fig. 89. 2c. From a pathologic standpoint, the World Health Organization recognizes 25 different types of primary bone malignancies, 48 with the exception of plasma cell myeloma, primary non-Hodgkin lymphoma of bone, chondrosarcoma, conventional osteosarcoma, and Ewing sarcoma. The remaining entities are, for the most part, very rare. Table 89.1. Screening. No population-based screening tests applicable to the detection of bone sarcomas exist. However, A number of syndromic conditions that predispose to the development of primary bone malignancies are known. Table 89.2. Many of the implicated genetic diseases, such as Rothman-Thompson and Werner syndromes, are exceedingly rare, and no clear algorithms exist for cancer screening. However, for more commonly encountered conditions that predispose to bone cancer, such as Li-Fraumeni syndrome, sarcoma screening recommendations, including whole-body magnetic resonance imaging (MRI), now exist. 11 for patients with predisposition diagnoses that are relatively commonly encountered in orthopedic oncology offices, such as hereditary multiple exostosis, multiple enchondromatosis, polystotic fibrous dysplasia, and Paget disease. Several practical, generalized guidelines can be offered. Plain radiographs of bones that are moderately to severely affected should be obtained yearly. A limited skeletal survey of involved areas including, as indicated, anterior posterior AP and lateral LAT views of the humerus and femur, AP views of the pelvis and distal extremities should be considered every 2 years. MRI, computed tomography CT, and positron emission tomography PT screening should be considered based on a patient's family history and personal clinical history. In all circumstances, care should be taken to limit radiation exposure with screening tests. However, as an individual ages, sarcoma risk increases, so routine surveillance surveys should be offered, especially for deep-seated locations such as the pelvis and shoulder girdle, where most sarcomas in these conditions will become manifest. 33 Because malignancies in these deep-seated areas can become relatively large before symptoms develop, vigilance of occult locations is especially warranted. Diagnosis. It is nearly universally true of practice patterns within the United States that patients suspected of being at risk for having a bone sarcoma have first had a plain radiographic examination ordered by their initial point of contact within the healthcare system. It is also very common for the primary care provider or general orthopedic surgeon to obtain an MRI scan of the affected area. Table 89.3. However, once concern for the possibility of a bone sarcoma has been raised, further diagnostic tests, many of which are of a specialized nature and involve radiation exposure, should be deferred, and the patient should be immediately referred to a multidisciplinary center skilled in sarcoma management. Figure 89.2 High-power hematoxylin and eosin stains of the most common sarcomas of bone. A conventional osteosarcoma is defined as having a high-grade spindle component, producing malignant osteoid. B. Chondrosarcoma is composed of spindle cells and atypical, plymorphic, hyperchromatic, multinucleated cartilage cells. C. Ewing sarcoma consists of small round blue cells with immunohistochemical and cytogenetic diagnostic conformation. Photomicrographs courtesy of Andrew E. Horvath, MD, PhD. History. Good medicine starts with a thorough history. Aggressive bone lesions often give rise to pain before a mass is noted. The nature of the discomfort, in terms of its intensity, frequency, duration, pattern, localization, and aggravating or alleviating factors, must be carefully assessed. The patient should be questioned regarding associated symptoms such as numbness, tingling, weakness, stiffness, instability, and gait abnormalities. Documentation of the characteristics of a mass, if present, must be obtained with respect to time course, growth pattern, and presence of localized erythema, warmth, and tenderness. Systemic findings such as fever, sweats, chills, weight loss, and fatigue need to be queried. A past personal and/or family medical history of conditions that predispose to bone malignancies must be explored. In many cases of even high-grade sarcomas, the history is that of an enlarging bone and soft tissue mass that is less painful than might be expected. Knowledge gained regarding history can direct further evaluation away from or toward non-neoplastic, pseudotumorous, aggressive, metabolic, or secondary conditions that can mimic primary bone malignancies, such as osteomyelitis, eosinophilic granuloma, giant cell tumor of bone, osteoblastoma, metastatic disease, or Paget disease. Fig. 89.3. Physical examination. Although it may not narrow the differential list considerably, a thorough physical examination remains an essential part of the diagnostic pathway for sarcomas of bone. The phaeolate spots can signal the presence of fibrous dysplasia. The integrity of the integumentary system should be assessed for erythema, warmth, and drainage over the primary site. The size, location, mobility, and consistency of any mass, if present, should be carefully described. The presence or absence of regional lymphadenopathy must be noted. Orthopedic parameters, including limb length, active and passive ranges of motion, joint stability, and gait pattern, need to be reviewed. Finally, a pertinent neurovascular exam must be completed. Diagnostic studies. Although neither highly sensitive nor specific, laboratory testing should not be neglected in the evaluation of patients suspected of having a sarcoma of bone. Complete blood count, erythrocyte sedimentation rate, and creatinine protein level can be helpful in ruling out infection. Alkaline phosphatase and lactic dehydrogenase are sometimes elevated in skeletal sarcomas. Creatinine and calcium levels are also useful chemistry tests. Serum and urine immunoelectrophoretic analyses can assist in excluding myeloma, and a basic urinalysis can be used to screen for genitourinary health. Radiologic imaging represents the bulk of diagnostic studies for aggressive bone conditions. Plain bone genograms include orthogonal views of the primary skeletal site and 2 views of chest as an initial assessment of metastatic pulmonary disease. Nuclear medicine tests include technetium 99 meters total body bone scan TBBS, indium labeled white blood cell, and PT scans. A bone scan aids in determination of primary site activity and the presence or absence of polystotic or metastatic disease. An indium scan can examine the possibility of osteomyelitis. A PT or PT/CT scan quantifies metabolic activity in the primary site and helps to exclude occult metastasis. Although some centers and protocols rely on TBBS for osteosarcoma evaluation and surveillance, the utility of 18F-fluorodeoxyglucose PT/CT scanning in the management of patients with Ewing sarcoma is well established and should be considered to be a care standard. 52. 58. A dedicated chest CT scan is perhaps the most sensitive way to exclude distant disease in the lungs, which is the most common site of metastatic deposits in patients with sarcoma. CT scanning also has proven utility in studying axial primary sites and juxtacortical lesions as well as in predicting pathologic fracture risk. 59. Often, the best modality for documenting the extent of a primary bone and soft tissue mass is an MRI scan, which should include the entire involved bone to make sure that skip metastases are not present. Specialized cross-sectional studies, including magnetic resonance neurograms, magnetic resonance angiograms, and CT angiograms, are sometimes important to assist with surgical planning. Table 89.1. Primary bone malignancies according to World Health Organization classification. Chondrogenic tumors, chondrosarcoma, including primary and secondary variants. Grade 1, Grade 2, Grade 3 periosteo differentiated chondrosarcoma, mesenchymal chondrosarcoma, clear cell chondrosarcoma. Osteogenic tumors. Low-grade central osteosarcoma, conventional osteosarcoma, telangiectatic osteosarcoma, small cell osteosarcoma, peristeal osteosarcoma, periosteal osteosarcoma, high-grade surface osteosarcoma. Fibrogenic tumors. Fibrosarcoma of bone. Ewing sarcoma. Hematopoietic neoplasms. Plasma cell myeloma, solitary plasmacytoma of bone, primary non-Hodgkin lymphoma of bone. Notochordal tumors. Chordoma. Vascular tumors. Epithelioid hemangioendothelioma, angiosarcoma. Myogenic, lipogenic, and epithelial tumors. Leiomyosarcoma, liposarcoma, adenoma. Undifferentiated high-grade pleomorphic sarcoma. From Fletcher CDM, Bridge J.A., Hogenon P., et al., eds. Who classification of tumors of soft tissue and bone. 4th ed. Lyon, France. iPress, 2013. In Ewing sarcoma, many protocols and centers obtain bilateral bone marrow biopsies at initial diagnosis as a part of routine staging for metastasis. Based on emerging data, PT imaging has started to replace this approach at some centers. Table 89.2. Syndromes predisposing to primary bone malignancies. Chondrosarcoma, enchondromatosis, Ollier disease, Maffucci syndrome, osteochondromas. Multiple non-syndromic trichorhenophalangeal syndrome type 2, osteosarcoma. Aller-Gerold syndrome, Bloom syndrome, Liefraumeni syndrome 1 and 2. McCune-Albright syndrome, Mazur-Brage syndrome, Oslam syndrome, Packet disease of bone, polyostotic osteolytic dysplasia. Hereditary expansile rapidolino syndrome, retinoblastoma, Rothman-Thompson syndrome, Werner syndrome. Undifferentiated pleomorphic sarcoma of bone. Diaphyseal medullary sclerosis with undifferentiated pleomorphic sarcoma. Oslam, osteosarcoma, limb anomalies, and erythroid. Diagnostic studies for sarcomas of the bone. Laboratory studies. Serum, creatinine, calcium, alkaline phosphatase, lactate dehydrogenase, complete blood count, erythrocyte sedimentation rate, C-reactive protein, immunoelectrophoresis, urine. Urinalysis, immunoelectrophoresis. Radiologic studies. Plain radiographs, orthogonal views, nuclear medicine. Technetium 99 meters, total body bone scan, indium 111. Label, white blood cell scan, cross-sectional imaging. Primary site. Computed tomography with reconstruction images, magnetic resonance imaging, whole body. Fluorodeoxyglucose positron emission tomography/computed tomography. Pathologic studies. Percutaneous. Fine needle aspirate core needle image guided. Ultrasound computed tomography, open incisional/excisional. Figure 89.3. A 36-year-old woman presented with lower leg pain and inability to bear weight that developed while jogging. And B. Plain tibiofibular radiographs show a transverse distal tibial diaphyseal fracture through a very aggressive bone lesion. C. The total body bone scan revealed intense uptake not only in the tibial shaft but also in the ipsilateral sacroiliac region, indicating a polyostotic or metastatic process. E. An axial magnetic resonance scan image documented the presence of a large tibial bone and soft tissue mass. E. The benign diagnosis, which was suggested by the patient's history of familial Packet disease in her grandmother, mother, aunt, and uncle, was confirmed by incisional biopsy. F and G. Anterior, posterior, and lateral radiographs 2 years after fracture showed complete healing. The patient was successfully non-operatively managed with a long leg cast and subsequent bisphosphonate administration. In the case of suspected primary bone malignancy, supreme caution must be taken with respect to the manner in which the biopsy of the primary site is undertaken. Percutaneous fine needle or core procedures, especially when guided by imaging such as ultrasound, CT, or MRI scanning, can be successful in establishing a diagnosis even in deep anatomic locations, especially if a soft tissue mass is present. This method has the advantage maximizing sampling throughout the mass while minimizing contamination. 60. 67. Because sufficient material must be obtained to perform all histologic, immunohistochemical, flow cytometric, cytogenetic, and molecular studies, thereby allowing an accurate diagnosis. Open incisional biopsies are often warranted, especially in pediatric cases where multi-institutional protocol studies request centralized pathologic review and other specialized testing. Excisional resection biopsy can be considered for smaller lesions that can be completely excised with negative margins and without undue functional compromise. An atypical or low-grade chondrosarcoma arising in an osteochondroma is an example of this type of biopsy procedure. Whenever an open biopsy procedure is chosen, careful attention must be paid to incisional length short and placement in line with the definitive resection procedure. Dissection planes through rather than between muscular planes, and avoidance of neurovascular exposure, bleeding, and infection. 68. 71. A skilled musculoskeletal pathologist should be immediately available to review the frozen section, confirm the receipt of sufficient biopsy material, and perform direct handling of the specimen. 71. Improperly performed biopsies can delay the start of care, prompt inappropriate treatment, preclude limb salvage by causing infection or contamination, and otherwise result in local recurrence and amputation. The risk of diagnostic errors and complications increases by as much as 12-fold when the biopsy is improperly done. 69. Because of these grave medical and medical concerns, referral to a tertiary center skilled in the multidisciplinary bone sarcoma management prior to biopsy is strongly advised. Staging. Once all diagnostic studies are complete, formal oncologic staging concludes the pretreatment evaluation process. Staging should be performed according to tumor, metastases T&M guidelines with principles set forth by the American Joint Committee on Cancer. 72. For bone sarcomas, staging correlates directly with prognosis, which is of utmost importance when discussing expectations regarding outcomes with patients and families. Table 89.4. Management by diagnosis and stage. Systemic therapies for Ewing sarcoma. Chemotherapy for patients with newly diagnosed Ewing sarcoma. Prior to the routine use of chemotherapy, nearly all patients with newly diagnosed Ewing sarcoma developed distant metastatic disease and ultimately died. 73. 75. These observations underscore the nearly universal presence of occult micrometastatic disease in patients with Ewing sarcoma. Although local control measures surgery and/or radiotherapy are critical to the treatment of patients with Ewing sarcoma, systemic therapy is equally critical to attaining cure. Table 89. For American Joint Committee on Cancer prognostic stage groups for sarcomas of appendicular skeleton, trunk, skull, and facial bones. Stage I. Roman 3 NET, any Edmond of any G. From Ammon M.B., Edge S., Green F. et al., eds. Edge Cancer Staging Manual, 8th ed., New York. Springer International Publishing, 2017. Filmertone T12 T3 Tone T12 T3 NET, Nodes N0 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 No. Metastasis M0 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 Moni. Early single institution study suggested that the regimen of vincristine, doxorubicin, dactynomycin, and cyclophosphamide Vaca was active in Ewing sarcoma. 74. 76. Follow-up cooperative group trials established the efficacy of Vaca and began to refine this regimen for Ewing sarcoma. For example, the first North American intergroup Ewing sarcoma study ESI investigated the role of doxorubicin and whole lung radiation in the context of vincristine, dactynomycin, and cyclophosphamide VAC. 77. Patients with newly diagnosed disease were randomized to one of the following three arms: VAC, vacant, or VAC with whole lung radiation. Among 342 eligible patients randomized to VACA had significantly superior relapse-free survival compared to patients randomized to the other two arms. Patients randomized to receive VAC had the worst outcomes, and patients randomized to receive VAC with whole lung radiation had intermediate outcomes. These results not only established the importance of doxorubicin in the management of Ewing sarcoma but also demonstrated that whole lung radiation may prevent some cases of relapse even in the absence of documented lung metastasis. Other national groups adopted the VACA regimen with largely similar results. For example, the Cooperative Ewing Sarcoma Study CES-81 trial was a non-randomized trial evaluating VACA in patients with localized Ewing sarcoma. 78. This group reported a 5-year disease-free survival rate of 54%. In addition, they identified large tumor size and poor histologic necrosis to neoadjuvant chemotherapy as potential adverse prognostic factors in this setting. The United Kingdom Children's Cancer Study Group conducted a similar trial, although the doxorubicin dose intensity was lower than in other trials. 79. They reported a 5-year relapse-free survival rate of 41% and suggested that this inferior outcome may be due to lower doxorubicin dose intensity. The French Society of Pediatric Oncology also treated patients with VACA and reported a 4-year disease-free survival rate of 52%. 80. Subsequent trials have built on the success obtained with VACA. Strategies have included changing the dosing strategy in VACA and adding ifosfamide and etoposide I. The French E-80 trial used this first approach to study a more protracted VACA treatment schedule in which cyclophosphamide was delivered daily for 7 days each cycle, with cycles repeated at 2-week intervals. 81. In this non-randomized trial, outcomes appeared to be superior compared to previous trials, although more intensive local control measures were also prescribed in this trial. Nevertheless, these results suggested that more frequent chemotherapy cycles were beneficial or that more protracted cyclophosphamide exposure was beneficial. The second intergroup study, East Roman 2, also sought to clarify the optimal mode of administration of VACA. 82 patients with newly diagnosed localized non-pelvic disease were randomized to one of 2 different VACA schedules. In the intensive schedule, patients received higher doses of doxorubicin and cyclophosphamide given in cycles administered every 3 weeks. In the protracted schedule, patients received lower doses of these agents, and exposure to the cyclophosphamide was distributed across 6 sequential weeks. This design resulted in significantly greater early doxorubicin exposure in the intensive arm as well as a slightly higher cumulative doxorubicin exposure in that arm. Among 214 eligible patients, all outcome measures relapse-free, disease-free, and overall survival were superior for patients randomized to the intensive arm. These results emphasized the importance of early doxorubicin intensity and led to adoption of VACA administration in 3-week cycles as a standard approach in subsequent studies. Based on response rates of approximately 30% in patients with recurrent Ewing sarcoma, several groups investigated the role of ifosfamide or I in patients with newly diagnosed disease. The French cooperative group conducted a non-randomized trial in which ifosfamide replaced cyclophosphamide throughout neoadjuvant and adjuvant chemotherapy that also contained vincristine, doxorubicin, and dactinamycin. 83 outcomes of the 65 localized patients treated with this strategy were compared to 95 patients treated on a previous French trial in which all patients received cyclophosphamide. Replacing cyclophosphamide with ifosfamide did not appear to improve outcomes compared to historic controls, suggesting that ifosfamide without epoxide is not active in this setting or that eliminating cyclophosphamide exposure altogether was deleterious. A non-randomized trial from the United Kingdom Children's Cancer Study Group used a similar approach to study ifosfamide but yielded a different result. 84, a total of 201 patients with localized disease were non-randomly assigned to receive therapy with ifosfamide replacing cyclophosphamide. Compared to historic controls treated with cyclophosphamide, relapse-free and overall survival appeared more favorable with the use of ifosfamide. The CES-86 trial used a similar approach, although in a risk-stratified manner. 85 patients with small, localized extremity tumors received VACA, whereas patients with either large tumors or axial tumors had ifosfamide substituted for cyclophosphamide, vincristine, doxorubicin, ifosfamide, and dactinamycin VACA. Although patients treated with VACA were predicted to have inferior outcomes as a result of adverse baseline risk factors, event-free survival was similar compared to patients with lower-risk disease treated with VACA. These results suggested that the use of ifosfamide helped to mitigate the adverse impact of large tumor size and / or axial tumor site. An Italian cooperative group trial non-randomly evaluated the addition of ifosfamide to VACA in the neoadjuvant setting and the addition of IE in the adjuvant setting. 86. The trial included 160 patients with localized disease. Event-free and overall survival estimates were among the highest reported at that time, suggesting that ifosfamide and / or IE may have improved outcomes in this population. The most definitive trial on the role of IE was North American Intergroup Trial 1991. 87 patients with newly diagnosed Ewing sarcoma were randomized as study entry to receive either standard therapy with vincristine, doxorubicin, and cyclophosphamide VDC administered every 3 weeks or VDC cycles alternating every 3 weeks with IE cycles. All patients received the same duration of therapy and the same cumulative dose of doxorubicin, with dactinamycin substituted once patients received that cumulative doxorubicin dose. A total of 518 eligible patients were randomized, 398 of whom had localized disease as study entry. Among patients with localized disease, there was a statistically significant difference in 5-year event-free survival, 54% for patients randomized to VDC versus 69% for patients randomized to VDC/IE. The addition of IE to VDC did not improve outcomes for patients with metastatic disease at initial presentation. 8,788. This result established VDC/IE as a new North American standard of care for patients with newly diagnosed localized Ewing sarcoma. The next generation of clinical trials from the Children's Oncology Group COG sought to intensify the VDC/IE regimen. Intergroup Trial 154 was a randomized trial for patients with newly diagnosed localized Ewing sarcoma. 89 patients were randomized at study entry to receive standard dose VDC/IE every 3 weeks or higher dose VDC/IE. Patients in the experimental arm received higher doses of ifosfamide and cyclophosphamide during cycles of chemotherapy. All patients received approximately the same cumulative doses of chemotherapy such that patients on the experimental arm completed therapy earlier than patients on the standard arm. A total of 478 eligible patients were randomized. There was no statistically significant difference in event-free survival between the standard arm and the experimental arm, demonstrating that higher dose therapy did not improve outcomes. COG Protocol A31 was also a randomized trial for patients with newly diagnosed localized Ewing sarcoma. 90. This trial sought to intensify therapy not by dose escalation, but rather by decreasing the interval between chemotherapy cycles, interval compression. Patients were randomized at study entry to receive standard therapy with VDC/IE cycles alternating every 3 weeks or to the experimental arm with VDC/IE cycles alternating every 2 weeks. A total of 568 eligible patients were randomized. Patients randomized to the interval compressed arm had a significantly greater 5-year event-free survival, 73% versus 65% for patients randomized to the standard arm. This trial established interval compressed VDC/IE as a new standard approach for patients with localized Ewing sarcoma. Of note, the role of interval compression in patients with newly diagnosed metastatic Ewing sarcoma has not been evaluated. The European Intergroup Cooperative Ewing Sarcoma Study ISIS-92 trial sought to clarify the role of IE based on a risk classification strategy in which patients with small, localized tumors were deemed standard risk and patients with large localized tumors or any metastasis were deemed high risk. 91 all standard risk patients received initial therapy with VACA. These patients were then randomized to receive the same therapy in the adjuvant setting or the same therapy with cyclophosphamide substituting for ifosfamide. Among 155 randomized standard risk patients, There was no difference in event-free or overall survival between patients who received ifosfamide or cyclophosphamide in the adjuvant setting. These results do not fully clarify the role of ifosfamide in this group because all patients received ifosfamide in the neoadjuvant setting. High-risk patients in the ISIS 92 trial were randomized at enrollment to receive VEA or VEA plus etoposide. 91 among 492 randomized high-risk patients, there was a trend favoring the addition of etoposide. In particular, patients deemed high risk due to large localized tumors appeared to benefit from the addition of etoposide, whereas patients with metastatic disease did not appear to benefit from etoposide. These results mirror those obtained from 1991 in which the addition of IE benefited patients with localized disease but not patients with metastatic disease. Based on this current body of evidence, the standard approach for newly diagnosed patients with localized Ewing sarcoma in North America is to use interval-compressed VDC/IE according to A31. Many clinicians use the same regimen for patients with newly diagnosed metastatic disease, although data supporting the benefit of IE or of interval compression are lacking in this population. For both groups, participation in a cooperative group clinical trial should be strongly considered. Chemotherapy for patients with recurrent Ewing sarcoma. Historically, patients with recurrent Ewing sarcoma had few systemic options. Many such patients were retreated, with chemotherapy combinations used as part of initial therapy. One series reported responses and durable remissions in patients treated with this strategy at relapse. 92 additional data suggest that higher dose ifosfamide 15G/mPro may be active in patients with recurrent Ewing sarcoma who were treated with lower doses of ifosfamide as part of initial therapy. 93 given greater options, many clinicians now opt to treat patients with new agents not previously used as part of initial therapy. Currently, patients with recurrent Ewing sarcoma are candidates for clinical trials of novel agents or may be treated with a number of salvage chemotherapy regimens with documented activity in this setting. The combination of gemcitabine with docetaxel has shown modest activity in patients with recurrent Ewing sarcoma. Two single-institution case series reported no responses among 4 patients with recurrent Ewing sarcoma. 9,495 A formal phase Roman II trial of standard doses of gemcitabine and docetaxel reported 2 patients with partial responses among 14 patients with recurrent Ewing sarcoma. 96 in contrast. Another case series reported 4 of 6 patients with recurrent Ewing sarcoma with objective responses with the use of higher dose gemcitabine and docetaxel, suggesting that higher doses of this regimen may have greater activity in this disease. 97 A formal phase Roman II trial of higher dose gemcitabine together with standard dose docetaxel reported 1 patient with a partial response among 7 patients with recurrent Ewing sarcoma. 98 taken together, these findings suggest a limited role for this regimen in the management of patients with recurrent Ewing sarcoma. Camptothecin-based regimens are currently the most active available chemotherapy regimens for patients with relapsed Ewing sarcoma. The combination of topotecan with cyclophosphamide has shown activity in this population. A pediatric oncology group POG phase Roman II trial of this combination included 17 patients with relapsed Ewing sarcoma, 2 patients with complete responses, and 4 patients with partial responses for an objective response rate of 36%. 99 A retrospective analysis from a German cooperative group included 49 patients with relapsed Ewing sarcoma and disease evaluable for response. 100 on initial response assessment, 16 patients 33% had a partial response. Based on these findings in patients with recurrent Ewing sarcoma, the COG conducted a trial in patients with newly diagnosed metastatic Ewing sarcoma in which patients received an initial window of therapy with either 2 courses of topotecan monotherapy or topotecan plus cyclophosphamide. 101 topotecan monotherapy had only modest activity, but 2 courses of the combination of topotecan plus cyclophosphamide resulted in a response rate of 57%. Based on these promising results in patients with relapsed or metastatic Ewing sarcoma, a recent COG trial for patients with newly diagnosed localized disease and 1,031 randomized patients to interval compressed VDC/IE to interval compressed VDC/IE with addition alternating blocks of topotecan and cyclophosphamide NCT 01-231-906. Results are pending at this time. The combination of irinotecan and temozolomide has also shown activity in patients with relapsed Ewing sarcoma. In the initial pediatric phase I trial of this regimen, 3 of 7 patients with Ewing sarcoma had objective responses. 102 A multicenter retrospective analysis of 14 patients treated with this regimen showed a response rate of 29%. 103 follow-up retrospective studies from other institutions reported response rate 60% in this same population. 104,105 This combination is less myelosuppressive than topotecan and cyclophosphamide and may be given as an oral regimen. Given these properties, this combination may serve as a backbone for the development of new regimens that combine chemotherapy with novel agents. Role of high-dose chemotherapy for patients with Ewing sarcoma. Given the finding that Ewing sarcoma is a chemosensitive tumor, several groups have evaluated the role of high-dose chemotherapy with autologous stem cell rescue in selected patients with high-risk disease. A single-institution retrospective study reported on the role of this approach in patients with recurrent Ewing sarcoma. 106 on univariate analysis. Patients who received high-dose chemotherapy had superior overall survival. To try to control for selection bias that may have led to selection of the most favorable patients to receive high-dose chemotherapy, this group performed a multivariate survival analysis. Receipt of high-dose chemotherapy as a component of relapse therapy was associated with improved survival, even after controlling for variables thought to be prognostic at relapse, such as response to salvage therapy and time from diagnosis to relapse. The majority of studies evaluating this modality have focused on patients with newly diagnosed metastatic Ewing sarcoma. Given the radiosensitivity of Ewing sarcoma, the Children's Cancer Group conducted a trial evaluating high-dose therapy using melphalan, etoposide, and total body radiation as conditioning. 132 patients with newly diagnosed disease with metastasis to the bone and/or bone marrow were non-randomly assigned to high-dose therapy following induction chemotherapy. Event-free survival was 20% at 2 years and was identical to a historic control group treated with standard dose chemotherapy, indicating that this regimen did not improve outcomes in this very high-risk patient population. A series of multicenter trials treated patients with high-dose therapy with busulfan and melphalan conditioning. 108,109 This approach appeared to be feasible following initial induction chemotherapy, although whether outcomes were improved by this approach is not clear in these initial and controlled trials. The Euro-Ewing group applied this approach to a larger group of patients with metastatic disease beyond isolated lung metastasis. 110 In this very high-risk patient population, 3-year event-free survival was 27%. Suggesting that any improvement in outcome from high-dose therapy in that context was incremental. Likewise, a randomized trial of this approach versus continued chemotherapy in patients with isolated lung metastasis has been reported in preliminary form and showed no advantage to high-dose chemotherapy. 111. One non-randomized trial evaluated the role of high-dose chemotherapy in patients with high-risk localized Ewing sarcoma. 112 patients received a common induction chemotherapy regimen and had response assessed at the time of local control by histology for patients who underwent surgical local control or by imaging for patients who received radiation for local control. Patients with a poor response to induction chemotherapy were non-randomly assigned to receive high-dose chemotherapy with busulfan and melphalan conditioning. Only a subset of patients assigned to receive high-dose chemotherapy did so. This selected subset had an event-free survival rate that was similar to patients with a good response who received ongoing standard dose chemotherapy. Patients with a poor response to induction who did not go on to receive high-dose therapy had significantly inferior outcomes. These results suggest that high-dose therapy may have abrogated the anticipated poor outcomes for patients with a poor response to induction chemotherapy. The role of high-dose chemotherapy in high-risk localized Ewing sarcoma has since been evaluated in a randomized trial. Patients with newly diagnosed Ewing sarcoma in either a large tumor volume or poor response to initial chemotherapy were eligible. All patients received induction chemotherapy with vincristine, ifosfamide, doxorubicin, and etoposide. 113 patients randomized to undergo high-dose chemotherapy received conditioning with busulfan and melphalan. Patients randomized to receive ongoing chemotherapy received the combination of vincristine, doxorubicin, and ifosfamide. The results have been presented in preliminary manner and demonstrate a survival advantage for patients randomized to high-dose chemotherapy. Whether similar results would be observed in the context of intensive North American chemotherapy is unknown. 114 novel agents for patients with Ewing sarcoma. Despite understanding the critical role of EWS-RON fusion oncogenes in the pathogenesis of Ewing sarcoma, strategies to target EWS-RON fusion oncogenes and oncoproteins have been difficult to develop. One group used gene expression profiling to identify existing drugs that replicate the gene expression profile associated with EWS-RON/FL-IONI knockdown. 115 Cytarabine was one of the most effective drugs in modulating the gene expression profile to emulate that of Ewing sarcoma cells subjected to EWS-RON/FL-IONI knockdown. The COG then conducted a phase Roman II trial of cytarabine in patients with relapsed Ewing sarcoma, with no responses among 10 patients. 116. Another novel agent, YK4-279, was developed to interfere with the interaction of EWS-FL-IONI protein and RNA helicase A, an important mediator of EWS-FL-IONI. 117. This agent is now in early phase clinical trials. A high-throughput screening study sought to identify existing agents that were able to reduce expression of EWS-FL-IONI target genes. 118. Mifamycin was the lead compound emerging from this screening. Follow-up experiments demonstrated preclinical activity against Ewing sarcoma models, leading to a clinical trial that closed early due to toxicity and lack of activity. 119. Other novel approaches have tried to exploit additional vulnerabilities identified in laboratory studies of this disease. For example, a large body of literature has suggested that anti-angiogenic strategies would be active against Ewing sarcoma. 120. Based on these findings, several trials have been conducted. The COG conducted a trial using VDC/I together with metronomic vinblastine and celecoxib in patients with newly diagnosed metastatic Ewing sarcoma. 121. This regimen was tolerable, but outcomes did not appear different from previous outcomes reported for this population. A pilot study of bevacizumab added to vincristine, irinotecan, and temozolomide included 2 patients with Ewing sarcoma, both with objective responses. 122. The insulin-like growth factor 1 receptor IgFONR has also been the subject of intense study in preclinical and clinical studies of Ewing sarcoma. The majority of Ewing sarcoma cells in tumor samples express IgFONR. 123. EWS-RON/FL-IONI expression reduces the expression of IGF-binding protein 3, an endogenous inhibitor of IgFONR pathway activation. 124. Preclinical studies of IgFONR small molecule inhibitors or inhibitory anti-IgFONR monoclonal antibodies have demonstrated robust activity against Ewing sarcoma models. 125. 128. In early phase clinical trials of IgFONR monoclonal antibodies, several patients with recurrent Ewing sarcoma demonstrated objective responses. 129,130 several phase Roman II trials specifically for patients with recurrent Ewing sarcoma were developed, and response rates of approximately 10% were observed without significant single-agent toxicity. 129,131, 133 based on these promising results in the recurrent setting, the COG is conducting a trial of an IgFONR monoclonal antibody together with VDC/IE for patients with newly diagnosed metastatic Ewing sarcoma. The mammalian target of rapamycin has also been implicated as a potential therapeutic target in Ewing sarcoma. Preclinical studies indicate that rapamycin can reduce levels of EWS/FLI protein and also induce an EWS-RON/FLI inactive gene expression signature. 115,134 in vitro and in vivo studies have shown antitumor activity of rapamycin as a single agent and in combination with cytotoxic chemotherapy. 135,136 to date. No trials of mammalian target of rapamycin inhibition specifically for patients with Ewing sarcoma have been conducted. However, in a phase I trial of ridaforlimab, one patient with advanced Ewing sarcoma had a confirmed partial response. 137. One institution conducted a trial in patients with high-risk Ewing sarcoma in which patients received a window of irinotecan, temozolomide, and temozolomide prior to receiving interval-compressed chemotherapy, with results pending at this time. Most recently, laboratory studies suggest that Ewing sarcoma may be sensitive to inhibition of polyadenosine diphosphate, ribose polymerase PARP. In a large-scale drug screen across myriad cancer histologies, Ewing sarcoma cell lines were found to be uniquely sensitive to the effects of a PARP inhibitor. 138. Another study sought to investigate the mechanism of this observation. 139. They noted that Ewing sarcoma cell lines have evidence of increased DNA damage, an effect that is potentiated in the presence of a PARP inhibitor. The use of a PARP inhibitor together with temozolomide resulted in dramatic preclinical responses compared to temozolomide alone or the PARP inhibitor alone. Based on these observations, a phase Roman II trial of olaparib monotherapy was conducted, without evidence of activity. 140 other trials of PARP inhibitors in combination with DNA-damaging chemotherapy are ongoing. Radiation therapy for patients with newly diagnosed Ewing sarcoma. Advances in radiation delivery and target definition together with improvements in chemotherapy and surgery approaches have improved local control for patients with Ewing sarcoma. However, the optimal local control approach remains unclear, largely due to lack of prospective studies that compare surgery with radiation in a randomized fashion. Instead, clinical studies recommend local control approaches commonly based on factors such as tumor size, tumor location, and institutional practices. Unfortunately, these same factors also influence clinical outcomes, and therefore, in the absence of adjustment for prognostic factors, analyses generally indicate that definitive radiation leads to higher rates of local recurrence and overall survival than definitive surgery. As a result, controversy has plagued decisions regarding local control measures, particularly for pelvic primaries, for which retrospective studies have indicated trends toward better local control after surgery compared with radiotherapy but failed to reach statistical significance. Such studies are fraught with selection bias because patients chosen for radiotherapy rather than resection tend to be those with larger tumors and less robust response to chemotherapy. 141,142 Nonetheless, when feasible, surgery is generally the preferred local therapy modality, and radiation is reserved for patients in whom anticipated morbidity from surgery is prohibitive. This leaves approximately 20% of children on COG studies receiving definitive radiation and 15% receiving adjuvant radiation for primary tumor control. Not only has a prospective randomized trial comparing surgery and radiotherapy as local control never occurred, such a study will never take place. Thus, we are left with interpretation of data collected for cohorts in which local control decisions are made based on parameters including tumor location, size, response to chemotherapy, patient age, and patient preference based on expected morbidity of each procedure. A recent study undertook comparative evaluation of local control strategies and localized Ewing sarcoma of bone and used propensity scores to control for differences among local control groups. This was accomplished by constructing multivariate models to assess the impact of local control approaches on clinical endpoints, independent of differences in their propensity to receive each local control approach. The cohort consisted of patients treated on 3 consecutive clinical trials, the experimental arm of INT91 and the standard arms of INT154 and A31, and this approach allowed the investigators to analyze a cohort that not only consisted of one of the largest sample sizes assessed to date for local control but also included patients treated with similar chemotherapy regimens. Whereas mode of local control was not associated with differences in overall disease control or overall survival, definitive radiation was associated with greater risk of local recurrence. However, the contribution of local failure to overall disease failure was rather limited, with local failure as a component of first event in only 49 of 131 disease failures and only 25 isolated local failures seen as a first episode of disease failure. 143. European studies have historically favored combined modality approaches for local control, with 63% of patients treated on ISIS-92 receiving combined surgery and radiation, 19% treated with surgery alone, and 18% with radiotherapy alone. Impressive local control rates were reported, with a local control rate of 95% when surgery was a component of local control compared with 75% when only radiotherapy was used. 144. A dearth of reports describes the durability of local control and the functional outcome of each approach, with a particular focus on cure rates. Contemporary clinical trials have emphasized event-free survival and overall survival as endpoints, but better information regarding functional outcomes is critical to inform decisions regarding local therapy modality for individual patients. Although postoperative radiation has gained favor for patients receiving combined modality therapy for local control, consideration should be given to preoperative radiation for a select group of patients with Ewing sarcoma. For these patients, the goal of preoperative radiotherapy is not to allow an inoperable tumor to become operable because the data for this approach are lacking for Ewing sarcoma. Rather, in patients for whom the choice of combined modality therapy is made, the rationale for preoperative radiation lies primarily in reducing side effects. Preoperative radiation may allow for smaller fields, less normal tissue exposure, and perhaps lower doses, as has been reported for adults in a prospective, randomized study of adults with soft tissue sarcomas. 145. Appropriate uses of radiotherapy for patients with newly diagnosed Ewing sarcoma include definitive radiation therapy for unresectable tumors and adjuvant radiation for tumors with incomplete surgical resection or intraoperative spill, chest wall tumors with ipsilateral pleural base secondary tumor nodules or positive pleural fluid cytology, and pathologically involved lymph nodes. Patients with complete resections R0 after neoadjuvant chemotherapy with a clear margin defined as no viable tumor at the cut surface should not receive radiotherapy. There are some subtle points to be highlighted. These guidelines incorporate not only the traditional factor of extent of surgical resection but also the parameter of percentage of tumor necrosis more commonly used in European protocols. Thus, for resected tumors that have 90% necrosis, if the tissue at the margin is bland scar or loose fibrous tissue, margin status should be considered negative and no postoperative radiation should be administered. However, if inflammatory tissue or coagulative tumor necrosis is present at the margin, the cytoarchitecture of the tumor cells is preserved. Postoperative radiotherapy is required. In contradistinction, for resected tumors with 90% necrosis, the cut surface of the resected tumor must be normal non-reactive tissue in order to be considered pathologically negative and radiotherapy avoided. Standard doses for postoperative radiation consist of 50.4 Gy for microscopic residual disease and 55.8 Gy for gross residual disease. For preoperative radiation, complete surgical excision should be undertaken within 2 weeks of 36 Gy of radiation. One note of caution is in order for the administration of radiation to patients with Ewing sarcoma. High-dose chemotherapy with busulfan and melphalan is now often used for patients with metastatic disease. In late 2003, the pediatric oncology community was alerted to possible severe complications after busulfan and melphalan high-dose chemotherapy and irradiation of the spinal cord. 146. A subsequent amendment restricted the radiation dose to the spinal cord to 30 Gy after busulfan and melphalan high-dose therapy. To add to these concerns, in 2005, reports from France described severe gastrointestinal toxicities after busulfan and melphalan and pelvic radiotherapy. Detailed analysis of the European Ewing Tumor Working Initiative of National Groups Ewing Tumor Studies. 99 studies show further serious toxicities with paraplegias and bowel obstructions leading to deaths. 147. However, in follow-up studies by the German Society for Pediatric Oncology and Hematology, similar severe toxicities were not observed. Although the German group did not confirm such severe toxicities, it must be noted that whereas the median follow-up for gastrointestinal side effects was longer than the longest period for development of radiation-associated bowel toxicities in France, the median follow-up for spine toxicities was only 7 months, and therefore, caution must be exercised. These differing findings may also be the result of lower doses and smaller volumes in the German Society for Pediatric Oncology and Hematology compared to those used in France. Given the critical role of radiotherapy for local control in many patients with Ewing sarcoma, if radiation is anticipated as part of a multimodality approach to local control in patients with axial tumor sites, consideration should be given to avoiding busulfan and melphalan high-dose therapy. 148. All metastases in Ewing sarcoma receive the same dose of 55.8 Gy as does gross disease at the primary site. However, these metastatic sites are often treated at the completion of chemotherapy, months after local control measures, because protracted external beam radiation to such sites might include significant bone marrow volumes and ultimately compromise the ability to administer chemotherapy. Thus, a role has emerged for hypofractionated stereotactic body radiotherapy (SBRT) for bone metastasis. Safety of administration of such large doses to highly targeted volumes has been aided by improvements in immobilization and image guidance techniques. Local control rates of 75% to 90% have been achieved by SBRT to spine metastasis using 18 to 30 Gy in a single fraction or 24 to 60 Gy in 5 fractions. 149. In the setting of metastatic bone sarcomas in children, the advantages of SBRT to bone metastasis are particularly appealing because completion of the radiation course in 1 to 5 fractions with equivalent disease control rates as conventional fractionation offers the added advantages of minimizing interruptions in systemic therapy and irradiation of smaller volumes. 150. A recent retrospective study has reported on results of SBRT for metastatic or recurrent Ewing sarcoma and osteosarcoma. Brown et al. 151 identified 14 patients with 27 lesions, 19 osteosarcomas and 8 Ewing sarcomas. Of these, 21 lesions were osseous and 6 were pulmonary. Median total dose was 40 Gy in 5 fractions. For surviving patients treated with curative intent, with median follow-up of 2.0 years range, 1.2 to 4.0 years, estimated 2-year local control was 85%. 8 toxicities included grade 2 myonecrosis, grade 2 avascular necrosis with pathologic fracture, and grade 3 sacroplexopathy. 151. This series helped propel a more comprehensive approach within a COG trial that assesses the feasibility and efficacy of administering SBRT to patients with metastatic Ewing sarcoma using 40 Gy in 5 fractions. Systemic therapies for osteosarcoma. Chemotherapy for patients with newly diagnosed osteosarcoma. Chemotherapy plays little role in the management of patients with low-grade or surface osteosarcoma. Historically, there was controversy about the role of chemotherapy in the management of patients with high-grade osteosarcoma. In light of this controversy, the multi-institutional osteosarcoma study MEOS was conducted. 152 patients with newly diagnosed localized extremity high-grade osteosarcoma were randomized after complete surgical resection to observation or to adjuvant chemotherapy. Chemotherapy consisted of 45 weeks of combination therapy including bleomycin, cyclophosphamide, and dactynomycin BCD cycles, high-dose methotrexate cycles targeted to achieve 1,000 μmp concentration, and cisplatin doxorubicin cycles. 36 eligible patients were randomized. Of the 18 patients randomized to adjuvant chemotherapy, 633, 3% experienced recurrence. Of the 18 patients randomized to observation, 1583, 3% experienced recurrence, and 2 of the 3 patients in this group who did not experience recurrence did not accept the outcome of the randomization and were treated with adjuvant chemotherapy. At 2 years from randomization, 66% of the patients randomized to receive adjuvant chemotherapy were relapse-free compared with only 17% of the patients randomized to observation. These results confirm the significant impact of chemotherapy on outcomes of high-grade osteosarcoma, and this trial established a new standard of care for this disease. The positive findings from the MEOS trial led to a number of subsequent trials designed to determine the optimal timing and type of chemotherapy. One trial compared adjuvant to neoadjuvant chemotherapy. 153 in this trial POG 8,651. Patients with newly diagnosed localized resectable high-grade osteosarcoma were randomized at study entry to undergo immediate surgical resection followed by 42 weeks of adjuvant chemotherapy or to receive 10 weeks of neoadjuvant chemotherapy followed by surgery and then 32 weeks of adjuvant chemotherapy. Aside from the difference in timing of surgical resection, all patients received the same 42 weeks of chemotherapy using a similar regimen to that used in the MEOS trial. A total of 100 eligible patients were randomized. Overall survival, event-free survival, and rates of limb salvage surgery were similar between the 2 arms of the trial, demonstrating that timing of surgical resection did not impact outcomes. With these results, the use of neoadjuvant chemotherapy became more widespread because this approach allows more time for surgical planning and also allows one to assess the extent of histologic necrosis in response to neoadjuvant chemotherapy. 2 older trials sought to clarify the role and optimal dosing of methotrexate in patients with newly diagnosed localized osteosarcoma. In an Italian trial, patients were randomized to receive methotrexate 200 mg/mPro or 2g/mPro as a component of multi-agent adjuvant chemotherapy. 154 outcomes were equivalent between the 2 groups. The United Kingdom Children's Cancer Study Group conducted a similar trial, although the doses of methotrexate under investigation were 690 mg/mPro or 7.5 g/mPro. 155 outcomes were again similar between the randomized groups, suggesting either that methotrexate does not contribute to disease control in osteosarcoma or that lower dose methotrexate is adequate for efficacy of this agent. A series of trials from the German/Austrian/Swiss Cooperative Osteosarcoma Study Group COS has clarified the use of cisplatin and doxorubicin in osteosarcoma. In the COS-80 trial, patients were randomized to chemotherapy with doxorubicin and methotrexate in all patients and either cisplatin or BCT. Outcomes were similar between arms. 156 in the COS-82 trial, patients were randomized to receive BCT and methotrexate or doxorubicin, cisplatin, and methotrexate. 157 patients with good histologic response at the time of surgery continued to receive that same chemotherapy, whereas patients with poor histologic response received different salvage regimens. A total of 125 evaluable patients were randomized. Patients randomized to the BCD arm with no doxorubicin or cisplatin in the neoadjuvant setting had significantly inferior metastasis-free survival, even though these patients with poor histologic response received doxorubicin and cisplatin in the adjuvant setting. Together with the results of COS-82, these findings highlighted the importance of early doxorubicin treatment in the management of osteosarcoma. The European Osteosarcoma Intergroup completed a randomized trial to assess the role of high-dose methotrexate in patients with newly diagnosed localized extremity osteosarcoma. 158 patients were randomized at study entry to chemotherapy with 6 cycles of doxorubicin and cisplatin or to that same regimen plus a dose of high-dose methotrexate given 10 days before each cycle of doxorubicin and cisplatin. Surgical resection was planned at the same time in both arms of the trial such that patients receiving doxorubicin and cisplatin had time to receive 3 cycles before surgery, whereas patients receiving methotrexate had time to receive 2 cycles before surgery. 99 patients were randomized to each arm of the trial. Disease-free survival was superior for patients randomized to doxorubicin and cisplatin 57% at 5 years compared to 41% for patients randomized to also receive methotrexate. Because all patients received the same planned cumulative dose of doxorubicin and cisplatin, these results highlighted the importance of dose intensity of these agents in the treatment of osteosarcoma. Moreover, these results called into question the role of methotrexate, although the dose used in this trial was lower than that used in more recent trials 8 versus 12 g/mPro, respectively. The European Osteosarcoma Intergroup conducted another randomized trial comparing 6 cycles of doxorubicin and cisplatin to a chemotherapy regimen similar to that used in the MEOS trial. 159 patients with newly diagnosed localized resectable osteosarcoma were eligible, and 391 eligible patients were randomized. The proportion of patients with a good histologic response to neoadjuvant chemotherapy was similar between randomized groups. Progression-free and overall survival estimates were nearly identical between randomized groups. Based on these findings, the group concluded that the shorter regimen with doxorubicin and cisplatin is preferable to the more complicated and longer regimen used in the MEOS trial. These results called into question the role of the BCD regimen used in the MEOS trial, which has now largely been abandoned. This group conducted a subsequent trial evaluating interval compression to dose intensify the doxorubicin-cisplatin regimen. 160 patients with newly diagnosed localized osteosarcoma were randomized to receive 6 cycles of doxorubicin-cisplatin administered either every 3 weeks or every 2 weeks. Surgical resection occurred after 2 cycles in the every 3-week arm and after 3 cycles in the every 2-week arm. A total of 497 eligible patients were randomized. Patients in the every 2-week arm had a higher likelihood of achieving a good histologic response, although they had also received an additional cycle of neoadjuvant chemotherapy. Overall survival and progression-free survival were similar between groups, indicating that dose intensification by interval compression did not improve outcomes in this setting. Based on promising results in patients with recurrent osteosarcoma, see the following text. Another series of trials has evaluated the role of ifosfamide or I in the treatment of patients with osteosarcoma. POG conducted a trial in patients with newly diagnosed metastatic osteosarcoma in which all patients received a window of therapy with 2 cycles of high-dose ifosfamide 12G/mTOR per cycle before surgical resection. 161 patients then received adjuvant therapy with high-dose methotrexate, doxorubicin-cisplatin, and additional high-dose ifosfamide. Of 27 patients with response-evaluable disease, 8 patients 30% had an objective radiographic response after the 2 cycles of window therapy. These results suggested that single-agent ifosfamide is an active regimen in this disease. The Italian sarcoma group conducted a randomized trial evaluating the role of ifosfamide both in neoadjuvant and adjuvant phases of therapy. 162 patients with localized osteosarcoma were randomized to receive methotrexate, cisplatin, and doxorubicin MAP with or without ifosfamide preoperatively. Patients randomized to not receive ifosfamide preoperatively could have ifosfamide added postoperatively if they had a poor histologic response to neoadjuvant chemotherapy without ifosfamide. Of 246 randomized patients, the proportion of patients with a good histologic response and event-free survival was similar between randomized groups. Given increased hematologic toxicity associated with the ifosfamide arm, the authors concluded that ifosfamide should be reserved for the adjuvant setting in patients with poor histologic response to neoadjuvant therapy without ifosfamide. North American Intergroup Study IT-133 was a randomized phase Roman 3 trial that included a comparison of patients treated with high-dose MAP chemotherapy or MAP plus ifosfamide 9G/mTOR per course. 163, a total of 677 patients with newly diagnosed localized osteosarcoma were randomized. Although the initial analysis of this randomization was complicated by a statistical interaction in the factorial design described subsequently, the subsequent analysis with longer follow-up determined that the addition of ifosfamide to MAP chemotherapy did not impact the event-free or overall survival. 164. The POG conducted a trial for patients with newly diagnosed metastatic osteosarcoma in which all patients received 2 courses of IE before surgical resection of the primary tumor. 165. The overall response rate after 2 courses of IE was 59%. This study design allowed histologic response of the primary tumor to be assessed, with 65% of patients having at least 90% tumor necrosis after 2 cycles of IE. The French Society of Pediatric Oncology OS94 trial sought to determine whether doxorubicin could be replaced by IE in the management of patients with newly diagnosed localized osteosarcoma. 166 patients were randomized at study entry to receive neoadjuvant chemotherapy with high-dose methotrexate in all patients and either doxorubicin or IE. Adjuvant therapy was determined by histologic response to neoadjuvant chemotherapy. The primary endpoint was histologic necrosis at the time of surgery. Among 234 evaluable patients, there was a significantly higher rate of good histologic necrosis in patients randomized to IE compared to doxorubicin. These results demonstrate the activity of IE in this setting, although they must be viewed in light of the fact that patients in the comparator arm received doxorubicin without cisplatin. The European American Osteosarcoma Study 1 sought to clarify further the role of IE in patients with newly diagnosed resectable osteosarcoma. All patients received neoadjuvant chemotherapy with MAP, which has become a consensus standard neoadjuvant chemotherapy regimen for patients with newly diagnosed osteosarcoma. Patients with a good histologic response 10% viable tumor were eligible for randomization evaluating the role of adjuvant interferon. See the following text. Patients without a good histologic response to neoadjuvant chemotherapy greater 10% viable tumor were eligible to be randomized to receive ongoing adjuvant chemotherapy with MAP or to receive ongoing adjuvant chemotherapy with MAP with the addition of IE. The addition of IE did not improve outcomes compared to ongoing MAP chemotherapy. 167. Chemotherapy for patients with recurrent osteosarcoma. Surgical resection of sites of recurrent disease remains a cornerstone of curative therapy at the time of relapse. Chemotherapy options are limited for patients with recurrent osteosarcoma. The combination of IE appears to be one of the most active regimens for this population. For example, an initial phase Roman 2 trial of this combination included 8 patients with recurrent osteosarcoma, 3 of whom had an objective response. 168. A follow-up phase Roman 2 trial from the French Society of Pediatric Oncology demonstrated a 48% response rate with this regimen in a population that included largely patients with first recurrent disease. 169. The combination of gemcitabine and docetaxel has also been investigated for patients with recurrent osteosarcoma. Single, institution case series have suggested some activity in this setting, mainly with disease stabilization, 9,597, although one group reported objective responses in 3 of 10 patients with recurrent osteosarcoma. 94. Based in part on these findings, 2 phase Roman 2 trials have been conducted. 96,176 in patients with recurrent osteosarcoma were enrolled across both trials, and only 2 patients had objective responses, partial response in both. These findings indicate that this regimen has only modest activity in this setting. Novel agents for patients with osteosarcoma. Multiple groups have attempted to improve outcomes for patients with advanced osteosarcoma by using novel agents. A subgroup of trials has targeted antigens that are overexpressed in some osteosarcomas. Based on reports of overexpression of human epidermal growth factor receptor 2 HER2 in a subset of osteosarcomas, the COG conducted a phase Roman-2 trial of trastuzumab together with intensive chemotherapy for patients with newly diagnosed HER2-expressing metastatic osteosarcoma. 171, a total of 41 patients with HER2-expressing tumors were not randomly assigned to receive trastuzumab plus chemotherapy, and 55 patients with HER2-negative tumors were not randomly assigned to receive chemotherapy. Event-free survival at 30 months was 32% in both cohorts, suggesting little benefit from the addition of trastuzumab. Osteosarcomas commonly express cell surface disintegrating GD12. 172, as such, patients with advanced osteosarcoma have been included in clinical trials of therapeutic monoclonal antibodies targeting GD12. In one phase I trial of a murine monoclonal antibody, one of two patients with osteosarcoma had a mixed response. 173 given high rates of human anti-mouse antibodies after receipt of the murine monoclonal antibody. The chimeric anti-GD12 antibody was generated and tested in a phase I trial. 174, one patient with osteosarcoma was treated and showed clinical evidence of disease stabilization, although the patient ultimately experienced disease progression. Based on these suggestions of clinical activity in osteosarcoma, several trials of anti-GD12 antibody in patients with advanced osteosarcoma are ongoing. Another group of trials has attempted to increase immune clearance of microscopic osteosarcoma cells. The use of neuronal tripeptide phosphatidylphenolalamine MTPP to stimulate antitumor macrophages has been intensely studied in osteosarcoma. In an initial phase Roman-2 trial, patients with recurrent or persistent pulmonary metastatic disease underwent surgical resection and then received adjuvant MTPP. 175 compared to historic controls treated with adjuvant chemotherapy. 24 weeks of MTPP prolonged progression-free survival from 4.5 to 9 months. These findings stimulated the development of a randomized phase Roman-3 clinical trial of the role of MTPP. North American intergroup study INT 133 included 677 patients with localized osteosarcoma randomized to one of 4 treatment arms, including 2 arms that included 36 weeks of adjuvant MTPP given together with adjuvant chemotherapy. 163 interpretation of this trial is complicated by the factorial trial design and by the presence of an interaction between the ifosfamide randomization described previously and the MTPP randomization. Specifically, MTPP appeared to prolong event-free survival only among patients also randomized to receive ifosfamide. Post-hoc analysis of the trial with additional follow-up was performed. These analyses showed a trend toward prolonged event-free survival as well as a statistically significant increase in overall survival among patients randomized to receive MTPP. 164, this result was independent of the results of the ifosfamide randomization. INT 133 also included a much smaller cohort of patients with newly diagnosed metastatic osteosarcoma. Patients randomized to receive MTPP had improved event-free and overall survival rates, although this portion of the trial was not powered to detect statistically significant differences in outcomes between randomized arms. 176, based in part on the findings from INT 133, MTPP obtained regulatory approval in Europe for patients with osteosarcoma, although it is not used in North America. In addition to MTPP, interferon has been studied as an immune strategy to reduce the risk of recurrence due to microscopic residual disease. Early results from Sweden demonstrated favorable outcomes in patients who received interferon as an adjuvant therapy following surgical resection of osteosarcoma, even in the absence of chemotherapy. 177, the COS-80 study included a randomization in which patients received or did not receive interferon in combination with multagen chemotherapy. 156, there was no difference in outcome according to randomized assignment. Given the results of the Swedish experience and concerns that interferon combined with chemotherapy may blunt the immunostimulatory effects of interferon, the European American Osteosarcoma Study 1 trial included another randomized assessment of the role of interferon in patients with newly diagnosed resectable osteosarcoma. Patients with a good histologic response to neoadjuvant chemotherapy were randomized to receive or not receive weekly pegylated interferon alpha-2 after the completion of all planned chemotherapy. Event-free survival was not statistically significantly different for patients randomized to interferon, indicating that adjuvant interferon does not improve outcomes in patients with a good response to neoadjuvant chemotherapy. 178. A large body of preclinical data demonstrates that bisphosphonates have direct antitumor activity in osteosarcoma. 179. 2 studies have investigated the safety of adding a bisphosphonate to standard chemotherapy regimens used in the treatment of osteosarcoma. In one study, monthly pamidronate was administered along with methotrexate, doxorubicin, and cisplatin. 180. The toxicity profile was similar to the expected toxicity profile associated with the chemotherapy backbone, and an increased incidence of complications associated with endoprostases was not observed. In the second study, zoldronic acid was administered every 4 to 6 weeks along with a chemotherapy backbone that included methotrexate, doxorubicin, cisplatin, ifosfamide, and epoxide. 181. Zoldronic acid at standard doses was tolerable together with this intensive backbone. A French randomized phase Roman-3 trial compared outcomes for patients randomized to treatment with chemotherapy and surgery to patients randomized to treatment with chemotherapy, surgery, and zoldronic acid. This trial was stopped early for futility, indicating that the addition of zoldronic acid does not improve outcomes in this context. 182. The Italian sarcoma group conducted a phase Roman-2 trial of the multi-targeted tyrosine kinase inhibitor sorafenib in patients with recurrent osteosarcoma. 183 35 patients older than 14 years old enrolled and received sorafenib 400 mg orally twice daily. 3 patients, 8% had confirmed partial responses. The 4-month progression-free survival rate was 46%, suggesting a degree of clinical benefit even in patients without an objective radiographic response. The lung is the most common site of failure in patients with osteosarcoma. Therefore, strategies to reduce the risk of pulmonary relapse are a high priority in this disease. At least 2 trials have investigated inhalational therapy specifically to target pulmonary disease in osteosarcoma. The COG conducted a phase Roman-2 trial of inhaled granulocyte macrophage colony-stimulating factor GM-CSF. 184 43 patients with first pulmonary relapse of osteosarcoma were treated with inhaled GM-CSF twice daily on alternating weeks. In a subset of patients who had not yet undergone resection of recurrent disease, staged bilateral thoracotomy allowed assessment of the biologic effects of inhaled GM-CSF. Inhaled GM-CSF did not result in significant recruitment of dendritic cells to lung metastasis and did not appear to improve event-free survival. Another trial investigated inhaled cisplatin for patients with relapsed osteosarcoma. 19 patients with advanced osteosarcoma involving the lung received inhaled cisplatin every 2 weeks. This therapy appeared tolerable with limited systemic toxicities. 1 patient had a confirmed partial response. An evaluation of inhaled cisplatin is ongoing as adjuvant therapy in patients with recurrent pulmonary metastatic disease that has been completely resected. NCT 01-650-090. 8 patients with advanced osteosarcoma were enrolled in a phase I trial of pediatric patients treated with escalating doses of the immune checkpoint inhibitor ipilimumab. 186 of 33 total patients enrolled on the trial were observed to have stable disease after 4 to 10 cycles. Among these 6 patients were patients with osteosarcoma. Survival in the entire cohort was improved in patients experiencing immune-related adverse events. Additional experience with programmed cell death protein 1 PD-1 inhibition is emerging, although early evidence suggests only modest activity in osteosarcoma. 187. Radiotherapy for patients with osteosarcoma. The mainstay of therapy for osteosarcoma has historically omitted radiation because osteosarcomas were thought to be radio-resistant. 188. However, surgery and chemotherapy lead to suboptimal local control in challenging disease sites such as the spine and pelvis. Relatively low doses of 30 to 56 Gy for spine osteosarcomas and 56 to 68 Gy for pelvic disease yielded very disappointing local control rates of 20% in the few patients who were irradiated in the cooperative osteosarcoma study group. 189,190. However, when higher radiation doses are used, better local control rates are achieved for unresectable or marginally resectable tumors. Doses of 60 Gy and 2.5 to 3 Gy once daily fractions or 1.25 to 1.5 Gy twice daily fractions resulted in local control of 60% in patients with unresectable osteosarcoma. 191. The role of particle radiotherapy for the treatment of unresectable or incompletely resected disease is promising as well. Kamada et al. 192 reported local control rates of 70% in patients with unresected osteosarcoma treated with carbon ions. Zernick et al. 193 reported on the Massachusetts General Hospital experience of 55 patients treated with a mean dose of 68.4 Gy standard deviation, 5.4 Gy for home 58, 2% range, 11% to 100% of the dose was delivered using protons. 5-year local control was 72%, and 5-year overall survival was 67%. Grade 3 to 4 late toxicities were seen in 31% of patients, and 2 patients died of treatment-related second malignancies. 193. Thus, with careful planning and respect for radiation tolerance of adjacent normal structures, radiation therapy can contribute to favorable clinical outcomes in patients with unresectable or marginally resectable osteosarcoma. Surgical therapies for local control of sarcomas of bone. The aforementioned review of systemic chemotherapeutic and local radiotherapeutic management options for bone sarcomas is necessarily directed toward the pediatric population because this is the most commonly affected population. However, the same principles can and should be applied to adults with Ewing sarcoma, intermediate to high-grade osteosarcoma, and high-grade and differentiated chondrosarcomas. 194,195 especially for patients younger than age 65 years old who are in good cardiac health. Neoadjuvant chemotherapy offers several potential advantages, including 1 immediate treatment not only of presumed micrometastatic disease but also of the primary tumor, to make local control easier and / or safer. 2 time for the patient and family to plan and consider various limb salvage versus amputation options. And 3 the opportunity to assess histologic response to chemotherapy, to guide adjuvant treatment. For patients with lower grade chondrosarcoma and osteosarcoma lesions, however, treatment usually consists of surgery only. Surgery for patients with low to intermediate grade chondrosarcoma and osteosarcoma. Enchondromas, sometimes referred to as low-grade cartilaginous neoplasms, are benign bone tumors that are exceedingly common, occurring in perhaps as much as 1% of the population. The distal femoral and proximal humeral metaphyseal regions are commonly affected, and patients with periarticular pain are often referred for orthopedic oncologic evaluation. In the vast majority of cases, the cartilage lesions are not thought to be the source of discomfort, and these lesions can be safely followed clinically and radiographically. 196 subsequent imaging that shows increased plain radiographic lucency, especially if coupled with cortical breakthrough on MRI scan, would raise concern that could prompt surgery. The histologic distinctions between a benign enchondroma, an atypical cartilaginous neoplasm, and a low-grade chondrosarcoma are notoriously difficult to establish, but myxoid material and bone permeation are thought to be in keeping with the diagnosis of chondrosarcoma. 197 When this diagnosis is suspected, a PT/CT scan, a preoperative image-guided biopsy, and an intraoperative frozen section can be of assistance in guiding treatment. Localized intraosseous grade 1 chondrosarcoma lesions can be safely and effectively treated with aggressive curettage, burring, and adjuvant application, for example, hydrogen peroxide washing and argon beam coagulation prior to cement packing. Fig. 89.4. By contrast, most grade 2 chondrosarcoma lesions are treated, where possible, with resection and reconstruction. Fig. 89.5. 198. Low-grade osteosarcoma lesions include central and juxtacortical, both periosteal and periosteal forms. Local control is accomplished with wide resection with negative margins. Reconstruction can generally be accomplished by allografts secured with internal fixation 41 or with endoprostheses. The treatment of grade 2 periosteal chondroblastic osteosarcomas, which often involve the anterior tibial shaft, is controversial as far as chemotherapy is concerned. 42,199,200 surgery consists of wide resection and reconstruction if possible, although amputation is sometimes necessary for distal lesions. Fig. 89.6. Surgery for patients with high-grade sarcomas of bone. A comparative study of local control strategies and localized Ewing sarcoma of bone showed that mode of local control surgery versus radiation therapy was not related significantly to event-free survival, overall survival, or distant failure. However, the risk of local failure was greater for radiation compared with surgery. 143. Thus, many patients with Ewing sarcoma, particularly extremity lesions, will undergo surgical resection. If margins are negative, adjuvant radiation can be avoided, thus minimizing the complications of growth arrest, deformity, skin and soft tissue inerration, lymphedema, arthrofibrosis, osteonecrosis, fracture, and secondary malignancy. In general, then, surgical local control measures for patients with high-grade sarcomas of bone, whether Ewing sarcoma, chondrosarcoma grade 3, dedifferentiated, mesenchymal, and clear cell, osteosarcoma conventional, telangiectatic, small cell, and high-grade surface, or other subtypes fibrosarcoma, angiosarcoma, leiomyosarcoma, and undifferentiated plymorphic, can be considered together. In many respects, the ultimate recommendation of a particular surgical control option rests less on histologic subtype of high-grade sarcoma than on a host of other factors, including patient age, disease stage, anatomic location, expected response to induction therapy, and patient or family socioeconomic and cultural factors, as well as capabilities and biases of the treatment team. Thus, surgical local control planning for each high-grade bone sarcoma patient must be individualized. Figure 89.4a. A 53-year-old woman presented with a rather subtle plain radiographic finding of a proximal humeral metaphyseal lucency after an area of uptake was noted on a screening bone scan obtained for her history of breast cancer. E. A T12-weighted axial image showed near perforation of the lateral proximal humeral cortex by a multilobulated cartilage tumor. Her computed tomography, guided needle, and final pathology were consistent with the diagnosis of an atypical cartilaginous neoplasm/low-grade chondrosarcoma, and she underwent aggressive intralesional treatment consisting of curettage, burring, hydrogen peroxide application, and cement packing. C. 3-year postoperative film showed no sign of local recurrence, and she remained asymptomatic. Amputation versus limb salvage. Given the choice, most, but not all, patients and families would select limb salvage as a local control option over amputation. With advanced imaging and modern reconstructive techniques, there exist few absolute contraindications to limb salvage. Relative contraindications to a limb salvage effort include major neurovascular involvement, very immature skeletal age, infection, lack of reconstructive, for example, very distal anatomic location or soft tissue coverage options, contamination secondary to biopsy technique and complications, inability to obtain oncologically acceptable margins, and pathologic fracture. The most common reason to recommend amputation is major neurologic involvement by the tumor. It should be kept in mind by patients, families, and treating physicians that the risk of local recurrence should not preclude a limb salvage effort. Although distant metastases and local recurrence after limb salvage sometimes are diagnosed at the same time, it is crucial to understand that there is no proof that local recurrence causes metastasis. Instead, both phenomena are likely related only insofar as they independently confirm the very aggressive nature of a particular tumor. Indeed, studies comparing limb salvage versus amputation have shown no statistically significant differences not only in terms of local recurrence and overall survival but also with regard to social, psychological, and functional outcomes. 201. 207 economic analyses have shown that external prosthetic fitting costs more than limb salvage over the long term. 208 and limb salvage is considered by many to be cosmetically superior. But patients with amputations have the advantage of needing fewer operations and being able to participate more readily in high-impact and endurance-type recreational activities. Figure 89.5a. A 74-year-old man with a history of left dorsal foot and ankle low-grade myxoid lip sarcoma presented nearly 5 years later with a painful right acetabular bone lesion noted on an anterior-posterior pelvis radiograph. The patient's tumor was evaluated with a magnetic resonance scan B and a positron emission tomography/computed tomography scan with a maximum standardized uptake value of 5.6. C. His computed tomography, guided biopsy, demonstrated an atypical chondrogenic neoplasm, but his final pathology after resection was consistent with a grade 2 chondrosarcoma. E. He was reconstructed with a complex cup cage cup total hip orthoplasty, and he was without evidence of disease at 1-year follow-up. Amputation, concepts and specialized techniques. Whether involving the upper or lower extremity, amputations should be performed at the most distal level that would assure negative surgical margins while optimizing functional outcome. In general, longer residual limbs offer better biomechanical advantage and more options for prosthetic fitting. However, a through-knee amputation is superior to a very short below-knee amputation because the femoral condyles provide an end-bearing residual limb. Major ablative amputations, such as hemiplovectomies, should be used only for curative intent or, rarely, for palliation when no acceptable alternative exists. 209. In cases of lower extremity amputation between the midfemoral and midtibial levels, the intraoperative application of an immediate postoperative prosthetic device has proven to be effective for enhancing wound healing, decreasing swelling, and allowing immediate 25 lb partial weight bearing on the first postoperative day, thereby minimizing the medical and psychological adverse effects of recumbency. Fig. 89.7. Although the immediate postoperative prosthetic is not recommended for dysvascular amputees, the technique has proven to be safe for oncology patients, including those receiving chemotherapy. 210. 213. Figure 89.6. A 17-year-old boy presented with a history of multiple exostosis secondary to radiation treatment for severe combined immunodeficiency syndrome as an infant. A. A plain radiograph of the proximal humerus demonstrated a characteristically benign exostosis. B. D. At an outside institution, he underwent intralesional excision of what was thought to be another exostosis, involving the anterior distal tibial cortex, as demonstrated in postoperative films in a clinical photo. Histologic review confirmed the diagnosis of grade 2 juxtacortical chondroblastic osteosarcoma. Given the distal location of the tumor, the patient elected to undergo a below-knee amputation with curative intent. However, he subsequently developed chest metastasis and succumbed to his disease more than 4 years later. Pediatric high-grade osteosarcoma and Ewing sarcoma commonly occur in the distal femur. For children of very young skeletal age, roughly girls younger than 8 years old and boys younger than 10 years old, use of expandable endoprostheses is not particularly feasible because of the number of operations necessary to ensure limb length equality and the attendant risks of infection, arthrofibrosis, and nerve palsy. 214,215 because a standard through femoral amputation in young individuals would result in a very short residual limb. Specialized reconstructive techniques have been devised. Rotationplasty uses the distal portion of the lower leg, ankle, and foot, with osteosynthesis of the proximal femoral and distal tibial diaphyses occurring after 180-degree rotation around the longitudinal axis. 216. 218. Although providing a longer residual limb that is functionally equivalent to a below-knee level, rotationplasty is not universally accepted in the United States for reasons of cosmesis and prosthetic fitting. An excellent alternative is a turn-up-plasty, in which the osteosynthesis of the proximal tibia and distal femur occurs after 180-degree rotation in the coronal plane. 219,220. This reconstruction preserves the viability of the proximal tibial physes so that the result is effectively a growing end bearing through knee amputation that is very cosmetically acceptable and easy to fit with an external prosthesis. Fig. 89.8. Figure 89.7a. An 18-year-old woman presented with a massive extracompartmental proximal fibular osteosarcoma that compromised lower extremity neurovascular structures, as shown in her T12 weighted axial magnetic resonance scan. B. After receiving neoadjuvant chemotherapy, she underwent a supracondylar above-knee amputation with immediate postoperative prosthetic fitting. C. Radiographic appearance of the immediate postoperative prosthetic, which is ready for fitting, with a pylon and prosthetic foot to allow ambulation. Figure 89.8a. Anterior posterior radiograph of a 3-year-old boy who presented with a large distal femoral high-grade conventional osteosarcoma. E. After receiving neoadjuvant chemotherapy, the patient underwent tibial turn-up-plasty, with the healed osteosynthesis site and preservation of the proximal tibial physoplate noted on a 14-month postoperative film. The result was functionally equivalent to a growing through knee amputation. Figure 89.9. Also, integrated transdermal anchorage system in a high transfemoral amputee allows ease of external prosthetic application and enhanced functional outcome. One final major advance for amputees is the development of percutaneous osseointegrated systems that maximize rehabilitation and function in transhumeral and high transfemoral amputees by eliminating the need for a standard prosthetic socket. These techniques, employed for more than 25 years by Brainmark and colleagues in Sweden, are gaining increasing acceptance throughout the world. 221,222. By being able to directly secure an external prosthetic device to the limb, patients enjoy a tremendous biomechanical advantage without the complications of socket wear. Fig. 89.9. Prospective studies have demonstrated very good rates of implant retention with excellent functional outcome in terms of prosthetic usage. 223,224. Limb salvage, options and recent advances. As mentioned previously, limb salvage can sometimes be achieved for high-grade bone sarcomas without surgery. This is quite commonly true for Ewing sarcoma, where radiation is used as monotherapy for local control. Unresectable high-grade osteosarcoma and chondrosarcoma lesions involving the mobile spine, sacrum, and pelvis can also be treated with radiation therapy alone in hopes of achieving palliation, if not local control. For skeletal sarcomas involving expendable bones such as the scapula, clavicle, radius, ulnar, ribs, iliac wing, and fibula, resection alone without reconstruction often results in a successful limb preservation outcome. Fig. 89.10. In most instances of limb salvage surgery, however, some form of reconstruction needs to be undertaken, and there are myriad methods. Autogenous bone grafts have historically been used for small defects, and in the present day, vascularized fibular transfers are sometimes used, particularly for proximal humeral tumors. Fig. 89. 11a. 225. 227. Frozen cadaveric osteoarticular and intercalary allografts were invoked for sarcoma reconstruction in past decades, but complications of non-union, infection, and fracture have limited their utility. 228. 230. Currently, allografts are most often used as part of alloprosthetic composites, principally in the proximal humerus, proximal femur, and proximal tibia. 231, figure 89.10, 8-year postoperative anterior posterior radiograph demonstrating medial clavicular resection for metastatic high-grade osteosarcoma in a 22-year-old woman with a history of distal femoral osteosarcoma treated 7 years previously. The majority of extremity limb salvage operations performed for high-grade sarcomas in the Western world are now accomplished with massive metallic endoprosthetic devices. These implants can be fabricated on a custom basis, but more frequently, modular segmental devices are assembled intraoperatively to conveniently replicate resection length. Fixation of these megaprostheses has traditionally been accomplished with long cemented or uncemented stems. A recent retrospective review of 2,174 patients who underwent conventional endoprosthetic reconstruction showed a high aseptic complication rate across anatomic sites. Soft tissue failure 12%, aseptic loosening 1%, structural failure 4%, and tumor progression 4%. 232 To avoid the complications of aseptic loosening secondary to stress shielding and particle-induced osteolysis, compressive osseointegration technology has been developed to allow stable fixation of endoprostheses to bone by way of an innovative spring-loaded system that applies up to 800 lb of compression force at the bone-prosthetic interface, thereby inducing bone hypertrophy. 237 The device also enables salvage of very short metaphyseal segments and allows ease of revision in cases of infection, mechanical failure, or infection. 241 Reports from several institutions have shown that compressive osseointegration reconstructions are similar or superior to conventional devices at intermediate term follow-up Fig. 89, 11b, d. 251 Continuing care, surveillance and palliation. In caring for patients with sarcomas of bone, it is important to maintain focus on the overarching priorities: 1 life, 2 limb, 3 limb function, 4 limb length equalization, and 5 cosmesis, in that order. 252 The lion's share of responsibility for overall survival lies with the medical and pediatric oncology team. The burdens of local control and functional outcome fall mostly to the radiation and orthopedic surgical oncologists. When the end of treatment occurs, it is essential to remember that the caring continues. Primary physicians are ill-equipped to provide specialized surveillance care for these exceedingly rare tumors. Although increasing conditional survival as the years progress is a cause for optimism, 253 clinical, laboratory, and radiologic parameters need to be followed for a decade or more, given the long tail of these potentially lethal conditions. The NCCN has recommended that physical examination, imaging radiograph, MR imaging with or without CT of the surgical site is clinically indicated, chest imaging every 6 months for 5 years and annually thereafter, and annual cross-sectional abdominal imaging. The evolving importance of PT/CT scan screening for accurate monitoring for local, regional, and distant recurrence has also been pointed out. 254, figure 89.11 Examples of extremity limb salvage reconstruction. A 5-year postoperative anterior posterior AP radiograph of a 30-year-old woman who underwent proximal humeral resection and reconstruction with a double-barreled vascularized fibular autograft for high-grade osteosarcoma. B 11-year postoperative AP film of a man who presented at age 70 years with a proximal femoral grade 2 chondrosarcoma after having undergone resection and compressive osseointegration reconstruction. C 14-year postoperative AP radiograph of a man who presented at age 53 years with a distal femoral grade 2 chondrosarcoma, note the bone hypertrophy at shaft prosthetic interface. E immediate postoperative lateral radiograph of a 12-year-old young girl with a high-grade proximal tibial osteosarcoma who underwent resection and reconstruction with a custom expandable compressive osseointegration hemiarthroplasty implant that allowed preservation of her distal femoral physeal plate. When sarcomas of bone are incurable because of progressive metastatic and or advanced unresectable locoregional disease, selective surgery, standard or experimental chemotherapy, targeted radiation, and expert symptom management must be offered to patients and their families. 255,256 Palliative care should be provided according to NCCN precepts. 257 The authors echo the sentiment of colleagues who have pointed out that we must always remember that as long as we have something to offer, patients hope for an improvement in their condition. It is this hope that keeps them alive. 255 References: 1. Bierman J.S., Shao W., Reed Dr., et al. NCCN Guidelines Insights, Bone Cancer, version 2.2017, J. Nato Compre Cancer Network 2017, 15.2, 15.5, 167, 2. Sejo R.L., Miller K.D., Gemel A. Cancer Statistics, 2018. Day Cancer J. Clin 2018, 68.1, 7, 30. 3. Sejo R., Nation M.D., Gemel A. Cancer Statistics, 2013. Say Cancer J. Clin 2013, 63.1, 1 on 30. 4. Ottaviani G., Schaff N., The Etiology of Osteosarcoma. Cancer Treat Res 2009, 15/15, 32. 5. Lesnick S.L., Ladney M. Molecular Pathogenesis of Ewing Sarcoma, New Therapeutic and Transcriptional Targets, and Reverend Pathol 2012, 7/14/5, 159. 6. Shuai K., Kotan Jansen A.M., Hojanon P.C., et al. Molecular Pathology and its Diagnostic Use in Bone Tumors. Cancergenic 2012, 255, 193, 204. 7. Lie F.B., Farmany J.F. Jr. Soft Tissue Sarcomas.